All right, so we're recording this for posterity's sake, so we can go back through and you guys can review this if you need to before the exam, which is exclusively on the epi section. But obviously, did you see a lot of biostat stuff starting to pop up here as well? Yes, obviously. Okay, so this is a very recent article. Did you guys notice when it came out? 2017, yeah, really recently. I actually saw an article, I think it was like ABC News or something like that popped up with it. I was like, oh, this seems interesting. Let's go ahead and look at that. Seems somewhat relevant. So we're going to go through. We'll answer the questions obviously on the sheet, and then we'll go off topic quite a bit, and I'll call on groups at random, thanks to my Google random number generator. So we're going to start out with Group 10. Can you stand, please? Thank you. You don't have to come to the front because we have a body in the way, but that's okay. So, starting off, can you kind of give the TLDR, if you will, or the summary essentially of the study? What was it looking at? What did it tell us?
Well, it was looking at metabolically healthy obese individuals and their risk for coronary heart disease versus metabolically healthy individuals. And that was their hypothesis, that the healthy obese individuals would be more at risk for those coronary heart disease, cerebrovascular disease, all that jazz, more than metabolically healthy individuals.
And what did they find?
They found that they were correct.
They were correct. So they think that they proved their hypothesis, right? Okay, so that's essentially kind of what the abstract is kind of telling us, like, hey, here's what we're looking at. Here's what our hypothesis is. Here's our study methods, right? We'll talk about methods a little bit later, and then here's our results. And essentially, they said, yes, we feel like we're vindicated here. Yes, we found a difference. So, okay, so trust me, people will be called on more than once. So you guys can sit down. Thank you so much. Next up, Group 6. It's not punishment for coming in late, but. Okay, so we mentioned kind of hypothesis, so kind of go into more detail on what the hypothesis really was for this kind of study. But obesity in what type of individuals? Okay, and so what does metabolically healthy mean in this case? What else? So the important thing here is to be specific, right? Because we need to look, because they made sure they specifically stated out like what they defined as being metabolically unhealthy versus healthy, right? So they said diabetes was one. What else did they say? Hyperlipidemia. What was the other one? Yep. So right, those are the big three, right? So does that include everything that could make you metabolically unhealthy? No, but those are kind of the big three, right? Those are kind of the big three ones you think of as being, some positive risk factors for cardiovascular disease or cerebrovascular accidents and things like that, right? So those are all good to think about. So they said, okay, people who are metabolically healthy, meaning they have few or none of these kind of these metabolic conditions, even though they're considered to be overweight or obese, versus those that are at what kind of weight? Yeah, based on normal weight, but none of these comorbidities, that they should have a higher amount of cardiovascular disease, right? So what would be the null hypothesis in the case? Yeah, so there'd be no difference, right? So the weight, really the only key difference here between the two groups would be that there's no difference between the two. So it doesn't matter if you're overweight or you're not, as long as you don't have these metabolic conditions, you shouldn't have an increased risk, right? This is basically the null hypothesis we're shooting for. Okay, thank you. Let's go to the next group. Oops. All right, Group 7. I like that sound. That's good. That sigh of defeat. Okay, so what was the design of the study?
So it was a cohort study with prospectively collected data from the Health Improvement Network database.
Okay, so it's a cohort study that was prospectively collected. So would you consider this a prospective or a retrospective study? I think it's prospective. Okay. So the question would be, what time frame were they looking at, right?
It was from 1995 to 2015.
Right. So did they start this study? Did they start this study back in 1995? Do you think?
Yes.
You think so? Probably not, right? Because you mentioned that. So kind of going back into study design, right? So when we say cohort study, what does that mean to us? So how do we define those groups of people?
By their BMI.
So in this case, we're setting up what the risk factors are, right? So we're looking at things like how do we stratify these people? In this case, it was based on their BMI and then what other condition, or what other aspect? Yeah, so looking at these metabolic conditions, right? So we're kind of stratify people based on that. So those are the cohorts, and then what are we looking for at the end of the study? Yeah, we're looking to see who had the outcomes we were looking at, right? So that would be a cohort study, even though this data was collected prospectively, because you started the program, say, back in 1995, and you measured up until, say, 2015. Because the researchers, I doubt they started it back in 1995. They probably were looking retrospectively, but all the data was prospective. So that was a little tricky from that standpoint. But basically, we can still run that kind of study, though, because we mentioned in the different study designs. Did you guys watch that video yet? Hopefully. Okay. Those kind of cohort studies, you can start retrospectively and then still look forward in time to see what those outcomes are. And that's still a valid study design, right? It's kind of a retrospective cohort study, which probably would have been a little bit clearer way to announce it. Yes, question?
Is it a retrospective cohort study or prospective or both?
I would say it's a retrospective cohort study, but the data they were saying specifically was collected prospectively, right? So the data was collected in real time in that program. It's just that when the researchers were looking, they already had all the data at their disposal, right? So in this case, it was considered, I would consider a retrospective sort of study, right? So that's why it got a little bit tricky there. So I like that. That's a question for that one. Okay, so what is the other? What would be the difference if I did this study as like a case control study? How would that differ based on how I stratified patients based versus a cohort? Can anyone give a lifeline? So we said this is a retrospective cohort study, right? We're defining people based on, or putting people into groups based on their risk factors, and we see what outcomes develop. How would that compare if I ran this study as like, say, a case control study?
Start with the outcomes and then figure out backwards risk factors.
Perfect, right? So in this case, I would look at people who had cardiovascular disease. I would look at people who had PVD. I would look at people who had CHF, and then I would look backwards to see what type of metabolic health they had. I would look to see what type of BMI they had. And so based on that, you would look to see what the odds ratios were to say, well, people who had peripheral vascular disease, they were 3 times as high risk to be, metabolically healthy yet obese, right? So they had that MHO definition there. So that would be the main difference there, right? Does that make sense, everyone? This would not be considered a randomized controlled trial, right? Because I didn't randomize any people to the groups. Like I can't really, take a bunch of people and say, okay, I'm going to feed you a bunch of McDonald's, make you overweight, and then I'm going to have you just eat broccoli for a year and then stratify. It doesn't really work like that. So that's why you can't really do like a randomized controlled study in a type of trial like this. All right, thank you. Let me sit down. Okay. Group 9. Okay, so tell me about this database where they pulled this information from. I told you we'd go off script. I know.
So it's a database that was apparently in the UK
Mm-hmm.
that tracked all these different health sort of statistics,
Mm-hmm.
people's weight, their age, their sex, their whether they smoke or not, things like that.
Mm-hmm.
I don't know if you're capable of that.
Yeah, so those are some key things we can kind of look at there. So we said it's prospectively gathered data, right? So you're kind of looking, the data is being collected in real time, essentially, as people are getting going to these providers. What was how do they decide who actually got into this program or not?
So that would be people who were in this Vision IT
Mm-hmm.
thing.
Which I guess seemed like the software they were using to kind of hook up to this thin monitoring program, right? So who would not get included in this kind of data, or in this database here?
People less than 18. That was one.
Right. So we'll talk about exclusion criteria in a little bit. But just if you imagine if you were going to go see your general practitioner over in the UK, what if they didn't have the program set up, right? Yeah, you wouldn't really be included at that point, right? And so that was one of the things they mentioned was that people were walking around upstairs. Anyway, so we kind of mentioned the article mentions that people sometimes would not be included until their provider actually instituted the program, right? So people that you would see, and that goes back to how long people got monitored for, and we'll look at that a little bit later when we're looking at some of the outcomes and whatnot. But not everyone's monitored for the same period of time, right? That's one of the key things to note there is not everyone is going to be from 1995 to 2015. A lot of people are going to be either coming into the program late, or some people will be leaving the program early, which is important, right? We talk about censoring data and whatnot. Good. And then so we mentioned, where was this study performed? Okay, so what implications do you think that has for the study?
You have to be careful applying it broadly to people from other cultures or other gene pools.
Okay, yeah, so what do you call that when you are able or not able to push that out to a larger population? There's a term. Generalizability, yeah. So we look at the generalizability of the data to see, like, okay, well, does this study, looking strictly, even though it's looking at a very large set of data, like we're looking at 3.5 million people roughly, which is a pretty big N, right? A lot of studies don't get an N that large. It's only UK patients, right? So it doesn't necessarily apply one-to-one to US patients, to people from Africa, to people from Japan, different things like that. So do you think that a study done in the UK, how generalizable do you think it is to the US population? Because we're probably going to be caring for probably pretty close, right? There might be some differences there, right? Depending on different, gender probably is about the same. You probably think the diet is roughly the same for the most part. You think certain nationalities might be more or less represented in the UK population versus here, so that may have some difference, but we overcome those differences by looking at how large of a number of people we're looking at, right? So if we only did this in like 30 patients from the UK, really limited generalizability. That's kind of a limited study regardless. But if we had 3.5 million, that's probably pretty good. That's a lot of people we're looking at. And so again, that helps us to regress back to the mean, and we cut out those kind of outliers. They kind of cancel one another out roughly. Okay, cool. Thank you. Okay. Group 8. Did I just call him number 8? Okay, 8, you can stand up. All right. She just said, yeah, of course you did, and then I wouldn't have called him. I'm just kidding. Okay, so in this case, what is the independent variable? Okay, so the BMI patient fell into, and then
the metabolic, like how many metabolic abnormalities they had, like some of them had 1 or 2, kind of mixed and matched.
Yeah, so we can kind of stratify people based on when their BMI, and then within that group, how many metabolic conditions they had. So if they had hyperlipidemia or diabetes or hypertension, they had 1, 2, or 3 essentially, right? Good. So what type of variable would you consider that to be?
We put ordinal for BMI.
Okay, so ordinal will be for BMI. That's good. And then
nominal for metabolic.
Okay, so why do you think nominal for metabolic?
Like we're thinking it's more of a category, like you can't assign a number to it.
I would agree with you for most of that. So I think BMI is certainly ordinal, and that kind of makes sense because we weren't just saying a BMI of 1 versus 2 versus 3 they broke them up into different categories, right? But certainly there's a relationship between a BMI less than 15 versus a BMI greater than 30, right? So there's some relationship there. There's an order to it, so we consider that an ordinal sort of variable. The metabolic conditions, though, I think are a little bit more tricky. So it would be one thing if it was like, yes, no, they have diabetes. Yes, no, they have hypertension. Yes, no, they have hyperlipidemia. But the way to kind of categorize it is if you were to look at the phenotypes, they kind of broke them down into, let me see, where's that at? It's easier on, actually, so if you were to look at it on this case here, let's see if we can zoom in. So you notice how they did it like underweight 0 metabolic abnormalities, underweight 1 or more, and they did normal weight 0, and then they kind of kept going up. So because they have that, they're saying that hyperlipidemia plus diabetes is worse than just diabetes alone. They kind of imply an order there, right? So the more metabolic conditions you have, they were assuming that you're going to have a higher risk essentially. So it kind of goes worse as you go down the list there. So I would almost consider that almost an ordinal sort of variable in those cases. But yeah, certainly the nominal category, you kind of think about that with the different individual metabolic conditions, but I would probably consider this ordinal overall when you break them down into categories like this. So you can certainly say that someone who's obese with 3 metabolic abnormalities is certainly, you would consider to be worse off from a metabolic standpoint than someone who is normal weight with 0 metabolic conditions, right? You guys can all make that leap of logic with me? So I think it makes good sense. So I would consider it kind of an ordinal type of variable. So that would be good. So that's an independent variable, as we mentioned, right? Why is that the independent?
Because it's like what you can change or what you're using to affect the thing you're measuring.
Yeah, because the researchers decided where to put people into different groups, right? So they could have changed it to change the BMI categories that they set it up to. They could have changed the metabolic conditions they were looking at. They could have done all of that. So that would be considered independent because we were able to change that, right? What would be your dependent variables?
We said one of the 4, or like developing one of the 4 cardiovascular diseases,
Mm-hmm.
the coronary heart disease, the cerebrovascular disease, the heart failure,
Okay, and so what type of variable would you consider that?
We said it nominal.
Okay, so why do you think nominal?
I do not know.
That's an honest answer.
It's more of a categorical, or you can put it into, it's not like associated with a number either. It's kind of,
Yeah, so and essentially if you look at the study, like what they did was kind of like a yes no thing, like yes did you get this, or yes or no did you not, right? So because of that, there's no and again, when did they exclude patients from the study? Like when did they stop measuring people? You guys look at that?
When they got the disease.
Yeah, when they had one of the events, it didn't have to be all 4 of them or 2 or 3 of them. Like once they got one of them, they're out, right? So that was when they eventually got censored at that point, which we'll talk more about later. But yeah, so it was one of those things where it was like yes or no, right? So like if you're looking at death on a study, you know it's a nominal variable because yes or no, you're either dead or alive, right? Obviously, alive is probably more than dead, I would think, but and then for these cases, we kind of consider it more like a nominal type of variable. That makes sense for everyone? Okay, good. All right, thank you. Let's see. All right, so let's see who the next group, the next victims. Group 4. All right, so where's my group 4? All right, stand up. All right, how are patients included or excluded from the trial? How do they get assigned to each group?
Inclusion and exclusion criteria.
Thank you. What were the inclusion exclusion criteria?
Oh, yeah, there it is. So
It's pretty simple for this one.
the exclusion's not having any prior CBD events, and they're included if they're older than 18.
Right, so basically anyone who's in this thin program, right? Because again, they weren't measuring everyone in the UK. There's a lot more than 3.5 million people there, but anyone who's actually in the thin program is kind of the inclusion. And then the one thing they're excluding people for was generally.
No prior events.
Yeah, so age was the big thing, and that they had a prior event, right? They wouldn't want to consider them in it because they already had the event they were concerned about. So it's really not what they were looking at, right? So if you already had a case of heart attack or PVD or what happens to be, they're not going to include you on that. Good. And then how do they assign people to the groups? Like how do so we saw there's like 14 different groups they broke them down into. Like how did they decide who got put into which group?
The body size phenotypes?
Good, yeah. So we did based on body size phenotypes and also the metabolic conditions. How do they figure out which BMI people were falling into?
Oh, it's from the generalized.
So did they use like just any BMI they took, or did they use the first one, the last one? When was the measurement done?
It was like the first thing that was put in.
Yeah, exactly, right. So it was the very first BMI they had encountered, right? So that's important because what could happen to someone's BMI over, say average, everyone's monitored for about 5 years. What could happen over that time? Could change, right? So somebody could have a much higher BMI at the end than when they started with, and some people could have a very low BMI compared to what they started with, right? So what would you consider that? It can introduce bias. It could be confounder, right? So if you have people who change weight very significantly, that could be a potential bias in skewing your data one way or the other, right? What do you think it's easier to do? Lose a bunch of weight and get a lower BMI, or gain a bunch of weight and get a higher BMI? Probably gain weight, right? It's harder for people to lose weight in a lot of cases. And so if anything, how do you think that would skew the results?
They misclassify people.
So yeah, people's classification could change over time. Do you think that would skew people towards better outcomes or worse outcomes? Probably worsened outcomes, right? So you think people who maybe had a normal BMI at the start, they might have had worsened outcomes as time went on because they ended up gaining a bunch of weight and they became less healthy, right? So if anything, that would skew towards finding a difference or not finding a difference. Well, probably not finding a difference, right? Because we're trying to show that people who are that are obese and they're metabolically healthy have a lot more outcomes than people who were healthy, normal weight, right? That was the kind of thing. So if these people are getting more sick as time goes on, they're going to look more similar to the obese group that had no metabolic conditions, right? So in that case, you'd actually be skewing more towards showing no difference when maybe there actually was one there, right? Or that's something we can really pick up on. So that is one limitation we might look at in the studies that people's weight can try and change over time, okay? Good. And then how about when they were defining their metabolic conditions? How do they do that? How do they determine, is someone hypertensive, do they have hyperlipidemia, do they have diabetes?
Based on their past medical history in their childhood.
Okay, so how could you tell that based off of this?
The diagnosis code for hypertension.
Okay.
The labs for they were on a hyperlipidemia medication.
Good, yeah, absolutely. So it's important to look at when you're defining who has diabetes, who has hypertension, how do they make that definition, right? A lot of times, what do they look at, as you mentioned with the hypertension measurement, or the hypertension categorization? He says based on.
How the diagnosis code, the ICD-10 code.
Okay, good. Yeah, so I don't know if they use ICD. There's a big list at the front. I don't know if they were using ICD-10 or not, but they were using some classification system to say, yes, you have hypertension or not, right? And so who makes that decision? Yeah, so the provider makes that decision. So what kind of possible limitations are there with that? Or yeah, someone misclassified somebody, or they forgot to code them as having hypertension, or there's lots of different little tiny biases that you can introduce there. So if they call it kind of a misclassification bias, right? But again, when you're dealing with 3.5 million people, chances are a lot of those kind of even out in the long run, and so hopefully you're going to have limited amount of bias introduced because of that. Okay, and then you mentioned the hyperlipidemia. How do they determine that?
They said just if you were on if they had a history of being on a lipid lowering medication.
Okay, good. So does that mean that those patients, so obviously they're on medications for it. Does that mean they have hyperlipidemia? Not necessarily. They could have already corrected the problem, right? They could have maybe seen maybe the LDL is already corrected. Maybe they're already helping with the atherosclerotic risk. Maybe that would skew them more to having better outcomes, right? So that could be another thing where you're making the sicker people, the people you think are going to be sicker, make them more similar to those that were metabolically healthy to begin with and underweight, or normal weight, I should say. So again, look, you're kind of teasing out these little tiny biases. You're like, okay, does this actually matter? Does this matter? Those kind of limitations. Because again, these guys are looking back at all this data. They need some easy way to kind of categorize these people. And so oftentimes things like prescription drug records can be one easy thing. Looking at ICD-10 codes are going to be another thing. But you have to know those inherent biases there, right? Good. The other thing, what's kind of a limitation of BMI? Yeah, so it's difficult to tell people who have a elevated BMI. Is it due to actual adipose tissue, or is it due to lean mass, right? And so that's again one of those things where they kind of go back to looking like, listen, this is a large population. At least we're looking at 3.5 million people. There's going to be some people who are probably like the bodybuilders of the group who have a really high BMI, but are like Arnold Schwarzenegger, versus those people who are just kind of the couch potatoes, run of the mill, obese patients. So because of that, they said it probably evens out. It's probably unlikely to be causing a big skewing of the data here, right? All right, thank you. Very good. Okay. Group 3. All right. So, next question. What were the outcome measures of the study?
So they stopped when one of the 4 presentations of CVD arose, which was coronary heart disease, cerebrovascular disease, heart failure, and PVD. And then also if they died.
Okay.
Off, obviously, too.
Okay, so what do you call that when you stop measuring a person after a certain point?
Excluded?
Yeah, certainly, yeah, so they're not going to be measured anymore, so I guess they kind of be considered excluded, but what do you call it like when someone bleeps over the F word? Censorship, yeah. So the data becomes censored at that point, right? So it's like kind of putting like little black bars over the patient and saying like, don't look at this anymore. So obviously they're dead. Can't really measure those people anymore because they're probably not going to develop any more disease at that point, right? Unless it's like they turn into a zombie, maybe. But in the case if you automatically get excluded once you have a heart attack, how could that skew the data?
They could have further problems. They could have other complications after that heart attack that could signify that they're unhealthy.
Mm-hmm. Yeah, so what would happen if you have an MI? What could be kind of a subsequent development after that? Damaging all that myocardial tissue, the ventricle's not working too great.
Another MI.
Maybe another MI. What else? My left ventricle is just not pumping very good. Like it's
Heart failure?
Yeah, heart failure, right? That's usually can be something that develops after an MI. So maybe those patients who would have developed heart failure don't get included in the heart failure numbers, right? So how would that skew our data?
It would make this would seem like better than it actually is. Because people are getting more and more.
Yeah. Yeah, so having one, kind of cardiovascular disease can kind of beget other ones, eventually. So it could skew your data to making these people seem like they're less sick than they may have actually become. All right, so that can be one inherent bias you have to consider when you're looking at the results there. So if anything, it would make the data look better. So if we find a difference, that probably says, hey, there actually is something here, right? So again, you're looking at these kind of negative and positive biases and how it's going to skew your data. And so that if you find a difference, it could either be due to these biases causing, kind of the data to look better, or it could be making it look worse. In this case, it would probably make it look worse, if anything, right? Does that kind of make sense?
Yeah.
Okay. Let's see, what else can we look at? Okay, so that's good for right now. I'll probably end up calling you guys later because it's a little short, but okay. How about group 2? Promise this is as random as I can make it. Okay, so summarize the results of the study. What do you think they found? Are the results statistically significant? Are they clinically significant?
So as the person's metabolic abnormalities increase, their chance of getting heart failure, all 4 of them increased.
All 4 of them increased?
Well, I meant in all 4 cases. So like in coronary heart disease, cerebrovascular disease, they increased with the metabolic abnormalities.
Okay, so more metabolic abnormalities they saw increased your risk for having these conditions. What about those patients who were metabolically healthy but obese versus those? Because again, what was our original hypothesis? Give him a lifeline.
It was that being obese puts you at a higher risk for developing the 4 things.
Yeah, so being metabolically healthy and obese, so you don't have diabetes, you don't have hypertension, no hyperlipidemia, but still being considered having a obese BMI, compared to those people who were normal weight with no metabolic conditions, the obese patients would have a higher outcomes of these events, right? So did they show that that was the case?
Well, each one varies, but like for instance, peripheral vascular disease, being obese with 0 metabolic abnormalities actually was the lowest, had the lowest incidence of peripheral vascular disease. Whereas being underweight or normal weight with 0 metabolic abnormalities, they had a greater risk.
So how do they quantify that risk? What was the test they used? This kind of goes back to the statistical methods that they use. We talked about how we categorize patients, we talked about their data collection and all of that, but how did they analyze these results? Anyone know? Yeah, so they used hazard ratios. What tests did they use to develop that? We didn't really talk about it in the lectures necessarily. That was used kind of subsequent to that. There's one right before that. Yeah, so use that Cox proportional hazard model. So again, you remember when we talked about the Kaplan-Meier survival curves, like how they kind of have those kind of stepwise approaches. People died off, they got out of the study essentially. But this is kind of the same thing we're doing here, because again, once a patient develops one of these conditions, one of these outcomes, they're automatically cut out of the study. So it's almost like they died essentially, right? So death versus an MI kind of is in the same categorization in this study here. Okay, so based on that, you can kind of figure out what the hazard ratio or what the risk is associated with these different conditions based on your phenotype, essentially, right? So there's a really good table down here that can kind of help us delineate all of this, right? And so they broke them up in each of the 4 categories, right? So each of the 4 outcomes we were looking at. So did you guys look at these graphs? Okay, so what does this graph mean? What's it telling me? Good. Okay, so each one of these boxes is surrounded by its confidence interval, right? So how can I tell if one of these is statistically significant? Good. So because again, we're doing a ratio here, right? So we're looking at the risk, and we're looking at the ratio versus which group? So we're looking at the ratio. So again, we're dividing one risk by another risk. What's our denominator? What's that bottom risk that we're looking at? What's our measure that we're kind of comparing everything to? Absolutely, right. So this is why you see the people with normal weight, 0 metabolic abnormalities are right there on the 1 line, because their risk is essentially 1, because that was what our comparator is going to be, right? So again, how many ever people had that condition? And we can see that in those kind of supplementary tables. Like that's 1. This is our baseline, right? Because we assume these are relatively the healthiest people that we were pulling from. So this should be our comparator. Okay. And so based on this, could you say they're underweight and had 1 or more metabolic abnormality? What would you say about this group? Yeah, so it would be statistically significant. They had an increased risk for developing coronary heart disease. Okay. And you kind of look at all of these. So in this case, the only people who had kind of a protective effect, if anything, might have been those who were underweight with 0 metabolic abnormalities. What do you kind of notice about the line there? Yeah, it crosses 1. So at that point, we consider it to be not statistically significant, right? So because the confidence interval is not narrow enough, we can't really say whether or not we consider this to be statistically significant, right? It could be a power error, but again, you're dealing with 3.5 million people. probably less likely to be due to power. It's probably not statistically significant difference there. Okay, so looking at just coronary heart disease, and again, the main comparator, our main hypothesis is going to be for people who were, say, overweight with zero metabolic conditions. What do you notice here? It's over 1, right? So it's they're going to be an increased risk, right? And so they actually give you the odd or the hazard ratios back up. So you guys have that available? Yeah, for coronary heart disease, for people who are that MHO, that metabolically healthy and obese. This is actually going to be this one right here. I don't know if anyone has that available. In the first section we talked about, let me see. Here we go. Look, so individuals who are overweight with zero metabolic abnormality had a hazard ratio of 1.3 with a confidence interval 1.27 to 1.34. So you guys sit down. I'm going to ask someone else follow-up question because I want to break all these down. Let's go group 12. Yes. All right. So group 12. So we see a hazard ratio of 1.3 with a 95% confidence interval 1.27 to 1.34. So we said that is statistically significant or not? Yes, because again, it does not cross 1, right? So we can, safely say this is statistically significant. How would you explain that to a patient? What would you tell somebody? So again, this came up like in ABC News. You might have someone come into your clinic and they're like, "Yo, I found this article. What does this mean? Can you tell me anything about this?" What do you think?
It means that if you have these, you're more likely to get the disease.
Okay. How much more likely? Does that mean I'm going to have a heart attack?
No, you are.
You may. You never know. Okay, so I have a higher risk. Does this mean I have a 30% chance of developing a heart attack? Well, I don't know. It says 1.3, so that means 30% higher than. Right. So I'm more likely, but the question is, you want to quantify that, right? So if someone says, "Hey, if I undergo surgery, am I going to die?" And you're like, "Well, there's a chance," and they're going to go, "Well, how much?" Like, you got to make it realistic for them. You got to make it so that people kind of have, they take it with the appropriate grain of salt, so they don't go, "Well, I'm not going to let you do surgery on me. You told me there's a chance I might die." I don't know if it's 99%. I don't know if it's 1%, but I don't want to risk it, right? So looking at this, how can anyone else shed some insight? How would you explain it to somebody?
It says it's statistically significant.
So statistically significant. So I would say to someone, well, based on, listen, like people who are normal, healthy weight, who have no metabolic conditions, they have a chance for having a heart attack. They have a chance for developing coronary heart disease, right? So there's already a baseline risk there for those people. The people who were metabolically overweight, who were overweight, had no metabolic conditions, they had a 30% increased risk over that. So they had 30% increased risk compared to those people. So again, the risk doesn't say 100% you're going to have it or 30% you're going to have a heart attack, but the chances are higher, right? About 30% higher than those if you were normal weight. That's kind of the way I would kind of explain it to people. Some people might have still some issues with that, but that's a little bit easier than saying like, well, it's an increased risk and it's statistically significant. They're going to be like, well, I don't know if I'm going to die or not, right? So you have to think about people with kind of limited medical knowledge because, again, they're just going to be getting this stuff off of ABC News that says like, these people are going to have an increased risk for dying. And they're going to come to you and be like, oh my gosh, am I going to die? Right, so you have to think about those kind of patients. Okay, good. So I'll let you guys sit down. So we saw those patients, and again, even for those that were obese, they had a hazard ratio of 1.49. So again, a 49% increased risk compared to those who had normal weight with no metabolic conditions, right? Okay, that makes sense. And again, that was statistically significant. So let's go with group 4. Group 4, stand up. Where's my group 4? Oh, there you go. Thank you. You might stand up again. And I'm calling you guys for a second time now. Okay, so did this hold true for every single group here? Did every single group have an increased risk for the outcomes? Good. Okay. So which one did they have maybe a decreased risk? So in all these cases, you see that the underweight patients, if anything, they either had a non-statistically significant difference between the baseline group or they had an increased risk here, right? So again, they were underweight with zero metabolic abnormalities. Their CVD risk was still increased. So maybe being underweight is a sign of poor health, right? It could be a sign of other things that are going on. So we can't conclude that. But which groups were actually protected, right? In which outcome? So we're looking at specific outcomes. Well, if you look at CVD, you can see. Yeah, so if they're overweight with zero metabolic conditions, you actually found they had a similar risk to those that were normal weight. So maybe my risk of having increased chance of stroke isn't really that high if I'm just metabolically healthy but otherwise overweight, right, versus obese. What other outcome? PVD. Yeah. So this is the kind of the oddball kind of thing because again, you would not kind of intuitively think of these patients as being protected against PVD because again, if you're overweight, you're thinking higher lipids, you're thinking, I guess these guys are metabolically healthy otherwise, but again, you think overweight patients, you think increased atherosclerosis, you think about increased risk for PVD, right? So this is kind of one of the interesting things they pulled out is you might have a little bit of a protective effect here, and you notice they have a decreased risk because why? Is less than 1 and it doesn't cross, right? So because they have a decreased risk compared to the baseline group. So if anything, I go back to my patient, who is say obese, but otherwise metabolically healthy, and I'll be listen, you have increased risk for stroke, you have increased risk for coronary heart disease, you have an increased risk for heart failure, but PVD, you're actually a little bit protected, if anything, at least based on this information. Now, if I did this study back in the US, would I find the same results? Maybe, maybe not. Hard to say, right? So again, it's one of those things where it could be a potential limitation based on location, things like that. Good. Okay, so you guys can sit down. That's good. So you guys can understand how to interpret these graphs, right? So this is useful. So how about let's see another group. Let's call another group. Group 12 again. They'll get their chance. What group are you guys? 5. Okay, we'll see when you guys come up. Okay, so we already said that our hypothesis was that patients who have no metabolic conditions, who are either obese or overweight, they're going to be increased risk for cardiovascular disease. Would you say that these results support that analysis or that hypothesis? So our initial hypothesis was that patients who are metabolically healthy but overweight or obese are going to have an increased risk for these outcomes. Does this data support that hypothesis? Yeah, so you said that yes, I would be able to reject the null hypothesis in all cases except for PVD, right? So that kind of makes sense. They can make those assumptions here. What do you notice about patients who are normal weight but have metabolic abnormalities? What do you notice about them based on these graphs here? Yeah, so even though they have a healthy normal weight, these metabolic conditions have still conferred some degree of increased risk, sometimes similar to that of patients who are obese. So what is useful to that information? How could you use that with your patients? Yeah, so it's like I don't have to do anything. I'm a normal weight guy. Like, why do I need to worry about this? I have a fat kid inside me. He likes to come out whenever there's Chinese buffets and things like that. No. No, that's not no. But I mean that sometimes you need to come up with kind of simple ways to explain these kind of complex issues, right? So you mentioned you might internally be unhealthy, even though externally you look fine, right? That's a great way to explain that to patients, right? Yeah, so absolutely. So just because you have like a normal healthy weight, you might be hypertensive, you might have increased lipids, you might be diabetic, right? These still need to be checked out because that still confers a risk. So I think that's kind of one of the interesting other side points to this is not just that you can be obese or overweight and not have these metabolic conditions and be at increased risk, but being normal healthy weight and still having these metabolic conditions can still put you at pretty increased risk as well, right? So I think that's another good takeaway point from the study here. Good. Okay, so you guys can sit down. Let's see what else. All right, so let's see which group is going to be next. Let me. Oh no, 5. That's weird. My mouse finger kept clicking. That's so odd. Okay. So, what do you think are some limitations of the study?
So they were saying that misclassification is like a big thing for the limitation. So if a patient transitioned to a higher weight class, be misclassified. If they were initially like a healthy overweight and then they become unhealthy, that's misclassification. They also didn't have access to like exercise or food habits. That could be a limitation.
What would you call those? if they're skewing the results of your data. Confounders, absolutely, yeah, those are confounders.
And they also said patients who were treated aggressively could skew for conservative estimates for people being healthy.
Yeah, so just because we have someone as being a prescription record for being treated for hyperlipidemia, which categorizes them as having a metabolic condition, does not mean they did not get that very well treated, right? And that would skew you towards those patients actually being healthier, right? So again, it's one of those things where like even if you have these conditions that are skewing you towards showing no difference, when you find a real difference there, it kind of shows you, yeah, there's probably actually something going on here, right? Good. What are the limitations? Or anything else? Yeah, so we can't tell lean body mass versus just adiposity there. Okay. Anything else? Good. So okay, so good. So you guys can sit down. So I have another question. You guys thought you were done, right? Not yet. Group 8. Has everyone been called on at least once? I'm missing everyone. Beyond which group are you guys?
No, one.
Huh?
One.
One hasn't been called yet? Oh, you guys sit down. I'm calling group 1. Group 1, stand up. Be honest, yeah. Come on. You guys don't learn anything if you're just sitting around. Okay. So one of the things they did, so they did these basic analyses here, right? So these make pretty good sense. One of the things they talked about is doing sensitivity analyses. What is that? See how insensitive people are when you call them, say, you're fat on the inside, and they get really offended.
How likely it is to show positive effects, I guess.
How do you perform a sensitivity analysis? What do we factor into it? Variables, good. So you look at different variables, like what? What are we looking at? So we're looking at, we're looking to see if individual factors in these patients are having an effect on the outcome, right? So what we can do is we can actually run these sensitivities to see, is smoking have an effect here, right? So what we can do is look at people who are never smokers to see this analysis. Again, you're basically just changing one variable to looking to see what the results come back as, right? To see if there are any big differences there, because that can be important. Because again, it could be one of these things where if a lot of these metabolically healthy people who are still obese, if all of them were smokers, which we found that they tend to have a higher proportion of those tend to be smokers, that may be skewing your results. And so by looking at things like age, and they ended up breaking them down between less than 65 and greater than 65. They looked at gender as being a factor here. They looked at smoking, as I mentioned. They looked at looking at different measurements for BMI instead of just looking at what was measured. I think they had some other panels that were looking at as well. By using those things, you can still try to see, like, okay, are we finding vastly different results? If we find things that look very, very similar, then that would kind of tell us that, okay, these results are going to be pretty robust, what we consider, right? So they're very unlikely to be due just to the people we looked at. They're likely due to this is an actual issue here, right? So if we look at, let me see here. Right, so they talk about sensitivity analyses here. So what they did was they looked at the metabolic status derived from these diagnostic codes or prescription records, and then they also looked at physical measurements in laboratory, right? So they did a different measure of determining BMI and determining their metabolic status in order to see if that had any difference. So again, that looks like that classification bias we might be introducing if we misclassify people for whatever reason. They also looked at, what else? And again, they're looking for magnitude of association, so you might be able to find that maybe guys have higher likelihood for developing these conditions than females are, and they can look for those differences there. And if you look at that, the additional tables here, you can look to see, like, okay, well, they broke it down based on sex, right? So you can see how the hazard ratios, I should say, how they differ amongst the different genders here, right? And again, still your normal weight with 0 abnormalities are going to be your reference points. That's always going to be 1. Right, because your risk for your baseline is always 1, and then you can kind of consider the different features here. So as long as they're showing generally similar results, you can tend to say, okay, well, age probably didn't have a big factor here, or gender did not have a big factor, and they kind of summarize those in an actual article. So they're finding basically, let's see here. Okay, so they also look at things like hormone replacement therapy. Why do you think that's important? Or oral contraceptives? Yeah, what can estrogen do to your cardiovascular system? Thromboembolism is a big one, right? So you worry about increased risk for thromboembolism, so that could be an additional factor there. And again, they found not a huge amount of differences there. That can be another important thing to consider, because obviously that's going to be affecting mainly your which type of patients? Female typically, right? And then let's see, they also were looking at things like type 1 diabetics, so they excluded the type 1 diabetics. Did that still show the same results? And probably in this case it actually did, right? So again, those sensitivity analyses are just to help us reinforce what we already showed, to show that, make sure that the results are going to be the same. Or if they're vastly different, and you show that, man, females really had a disproportionate amount of risk compared to males, then you can do a follow-up study. You can look at these female patients to see what was it about them that put them at an increased risk. Maybe there's some other thing that we didn't account for in this study, right? You can generate new hypotheses and maybe do some new research down the line. Okay, you guys can sit down. Does that kind of make sense? I know we didn't discuss those in the videos yet. I don't actually have to talk about sensitivity analysis too much, but okay. Let's see, anything else? So again, kind of the takeaways, which I think this graphic is pretty useful. And again, this is something you can show to your patients. Be like, okay, well, what does this actually show? And they were looking at patients, again, normal BMI versus having elevated BMI with no metabolic conditions. Looking at their risk, 49% increased risk of coronary heart disease. So pretty big increase there. 7% for CVD, so cerebrovascular disease, not a big issue there quite as much. But again, what do you think about this 96% increased risk for heart failure? Pretty significant, right? I would be pretty concerned about that, right? So I'm like, I should probably go hit the gym a little bit more than currently none at this time. But so again, these are things that can kind of help, convince your patients, right? Because they're going to see this stuff in the news. They're going to come back at you and be like, I heard chocolate helps me to reduce risk of cancer, and you can be like, well, the study was actually crap. Like the study, totally wrong. I don't know if you guys watched that John Oliver clip I put in the first set of videos. Like that kind of goes back and kind of shows you just kind of the biases that can be inherent in a lot of these articles. This is a very nicely done, very large scale article, which you don't always get these. And if you look at the journal that it came from, it was the, where's it at? It was like the Journal for American College of Cardiology, right? So even though it was a UK study, so it got published in the American College of Cardiology journal. So not every journal is created equal, right? So JAMA, pretty good journal there, right? Look at things like Nature, pretty good, But if you're looking at sometimes, and they're really sketchy sometimes because they'll change the name just a little bit. So for instance, Clinical Toxicology is the kind of go-to tox journal that we use. But there's the Journal of Clinical Toxicology is actually different, right? And so that's the one you can actually pay enough money and get your article basically published, even though it's kind of crap data, right? So again, be very careful. You can look at things like impact factor. Have I talked about that before? Impact factor is essentially a measurement of how good your journal is, and essentially looking at how often do you get cited from other articles, right? So again, if this article gets cited 900 times by different articles that get published over the course of years, that will feed back into this impact factor to see how big of an impact does this journal have overall. And so you can look at different subspecialties and find different journals and kind of figure out which ones are your go-to journals. So that way, if you work in dermatology, you'll figure out what your go-to derm journals are. If you work in toxicology, like I said, ClinTox is kind of the one that we go to as toxicologists. So there's different things like that. So not all journals create equal. Some of them you can just pay and get stuff published. So, okay. So any questions on that? How you guys feel about that? Pretty good? Is that useful at all? Go through and review this stuff? Okay. I think that pretty much does it for me. If you have any questions, though, please feel free to email me. I have a couple more videos to record and post up, but we have another couple weeks till we have our next in-class session. We'll do another journal club, and we'll do that and then a review. So that work for everyone? And then we'll have the test and we'll be done. So if anything else, I will see you guys next time.